One of the things we're wanting to do with the symposium is to come up with consensus about how to deal with this drug driving problem, and how do we find a consensus when we have the Office of National Drug Control Policy recommending per se laws, and we've seen that some states have per se laws. We have Mark saying don't do per se laws. Jeremy Davey this morning, his message was kind of just do it. There was something we should just do it. Don't hold back. And then we have the UK who have implemented their recent changes, which seems largely as a result of some political tension. And people spoke of, we have a policy challenge here. And is this a policy challenge or is this a political challenge? I agree with Mark. I think our minister was very good. I think New Zealand's trying to find a fairly middle ground of doing something and try to make that as much as possible informed by the evidence. So where do we go from here in trying to find a consensus? We've got time now to please help us find that consensus. Will it open it up? Questions from the floor. We have some handsome Drug Foundation staff members. So if you work for the Drug Foundation, you have to look good. Like this. We've take questions from the floor, but before we do that, do any of the panelists want to challenge each other first, and then I'm going to take some questions from the floor. Does anyone want to respond to anybody else? Yeah, Mark.
Well, just it seems to be one thing we learned very clearly now is that making policy on the basis of pretty 14-year-olds with vindictive parents is likely to get you the wrong answer. I think it's pretty scary that the U.S. and the U.K., which are the two supposedly civilized countries with the highest incarceration rates in the world, are rushing forward to do more unnecessary incarceration around this issue. One issue that has not come up, and this is not results that are well known, though the data are public, but John Calkins and Maria Cuellar at Carnegie Mellon have gone back and analyzed the National Survey on Drug Use and Health, looking not at the 30-day prevalence data, which is what everybody looks at. 30-day prevalence of cannabis use has not moved very much. It's probably up 15% from its trough in 1992. The number of people who report using 21 days or more per month is up a factor of 7 since 1992, which, since that's basically all of the consumption, means that the number of stoned hours in the country is up at least 5-fold over a 20-year period, over which period traffic fatalities have steadily trended down. I think that gives us an upper limit on how big the cannabis-impaired driving problem's likely to be. Now, it doesn't give us an upper limit on how bad the cannabis problem's likely to be, and I'm a little frustrated that neither side of the cannabis legalization debate seems to have a strategy for limiting the upsurge in heavy problematic cannabis use. But it just looks to me like driving is not one of the things we worry about.
I think the issue obviously was raised whether the UK government is using road safety law as a disguise around drug control. I'd say no, it's not, because it's been absolutely open that it is using road safety law for drug control. And we made that absolutely clear in our public consultation and in our impact assessment. We didn't do an estimate. We didn't take account of taking this sort of tough approach to the extent that it might reduce drug use generally, because we thought there might be just too many other factors. But we believed, the government, particularly the Prime Minister, believed it was worth taking a punt to see whether that could have quite a good effect on reducing drug use. Because if you think about it, if you've got less drug users, you're going to have less drug drivers. So that's the approach. It's quite a bold approach, and it's certainly not one I think Mark clearly doesn't agree with. I should also, I didn't have time to include in the presentation, but the Think campaign will use the material for educators to go into schools as well. I think probably the same in most countries, you have in the national curriculum we have personal, social, health and economic studies, which gives young people as the context of the society that they live in, so hopefully when they leave school, they leave as well-rounded human beings. And the drug educators have been quite excited about this new offence because young adults, every young adult wants to learn to drive. It's a rites of passage. And basically the choice is, if you want to learn to drive, don't take drugs, don't get into drugs. It's as simple as that, and we'll see if it works or not. Some indications are that drug use is coming down, particularly cannabis. The survey of 11 to 15-year-olds in 2001, 1 in 5 was taking illegal drugs. That's now dropped last year, 2013, dropped to half of that. So the government's approach to taking a zero-tolerance approach to illegal drug use has to align, well, the road safety law has to align with that approach.
Thank you. Questions from the floor? Put your hand up and then we'll get the microphones run over.
I'm sort of interested by this. You know, we know from the data is problematic, but there's pretty good reason to think that benzodiazepines are something we should be concerned with. Yeah. Both used as a medicine and both used. A lot of benzodiazepines are consumed in Europe now as a recreational drug or on the market. And yet, and then you look at cannabis, and the data there is much more equivocal, especially on its own. It's more problematic. Some of it points one way, some of it points the other way. And yet we see a lot of attention on cannabis and very, very far less attention on the sort of medicinal drugs issue. And you see some of the barriers there. And yet, if you want people not to drink, not to take drugs and drive, they're going to have to feel that the rules are fair and rationally applied and that they make sense. And have we got some sort of tension here between these different perspectives where we're really sort of picking and choosing where we're applying our pressure and where we're not applying our pressure?
So I'll start on that. You probably saw in the list of drugs that the benzodiazepines is included in the drug driving offence, but they took a risk-based approach to those limits. The expert panel identified them actually the third most prevalent drug in drug driving cases behind cannabis and cocaine, if we exclude alcohol in this. But it does have a significant medical use as well. So balancing that out with, as I said, the European Court of Human Rights, Article 8, we took the approach that we would take a risk-based limits for benzodiazepines. They might be too high. I think until we get screeners, so screeners we're going to just do cannabis and cocaine first of all, but there's nothing to stop any manufacturer submitting for type approval a benzodiazepine. The problem is they're all over the place. The limits are, they would have to concentrate on one or the other. So I think for the foreseeable future is the police will still be looking for evidence of impairment with any of those that are risk-based approaches because they won't have screeners available. This is for the UK. And if somebody doesn't have a legitimate medical defence and evidence that they are using the benzodiazepine legitimately, then the police can pursue both offences. They'll investigate both offences, and if it comes back above the specified limit, then they can drop the evidence of impairment and just pursue the per se limits offence.
Good.
Yeah, I agree with you. I think the benzos and some of these other things are far more risky from a public policy and a public risk perspective. And we have a fascinating problem in Baltimore Oh, yeah. We have a problem in Baltimore with our drug addicts that are on methadone maintenance. And it actually, they don't get a lot of effects on the methadone maintenance. And there are studies showing that opiates, long-term use of opiates actually don't impair that much. You develop tolerance to it. But what they do is they don't get any of the high effects. So they go down to Lexington Market and buy some benzos and then get high. And we're getting an increasing number of pedestrians coming into our hospital. And I'm trying to use this as a leverage to get support from the hospital to get my drug testing done without having to get consent from everybody to do the drug testing. But I think benzos is a big issue. And mixed with other things, either with the opiates or, in particular, with alcohol is even worse.
Martin, maybe I misunderstood. If the doctor prescribes benzos and hydrocodone and oxycodone for me, and I take them exactly as prescribed, and it knocks me out, or pretty much puts me in la-la land, and I drive, am I still legal? Even though I know that the effects...
No, you're not, because said at the outset we're maintaining the Section 4 impairment offence, so you would be done under the Section 4 impairment offence. So what I'm saying is the police for the new offence do not have to prove impairment, but the way they're going to enforce the offence until they have widespread use of screeners is to investigate both offences, so collect evidence of impairment. If you really are taking your medicine and you shouldn't have got behind the wheel, then they will do you under Section 4 and not consider Section 5A, unless there was evidence that you obtained the medicine illegitimately.
I want to stress the point that I made earlier, which is under the UK law, nobody who ever smokes cannabis can ever legally drive and know that he's behaving legally. So if the goal is simply to criminalize all cannabis use, it's a perfectly reasonable law. But other than that, it's a grossly unjust law, because there's no way you can know whether you're obeying it or not, because the pharmacology of cannabis, pharmacokinetics of cannabis are simply not predictable enough for you to know whether you're going to be positive, even for active THC, since THC is lipid soluble and will come back out into the bloodstream in a way that's not intoxicating, but is going to show up on the limits. And this just strikes me as an appallingly unjust piece of legislation.
I feel like I ought to respond to that. Well, we are specifying Delta 9, which THC was active ingredient, but we have had some inquiries about how much cannabis can I take? I mean, for a naive user, you'd probably only be able to you'd be over the limit if you took one joint within the last 6 hours. So that's pretty tough. But you have to also bear in mind that the margin of error is probably going to be an extra 30% on top of that. The half-life of THC is about 2 hours. So we're probably actually, from the incident or the stop, we're probably actually doubling the point at which we'll be charging from the actual moment when they were stopped and what was in their blood at that time. With the half-life and the margin of error, we're probably at least doubling.
And what's been the public reaction? Has it been favourable? And not just the general public, but what about police officers and others? Is it?
It's been favourable. I mean, they're more worried about how the hell do we actually get to grips with it, which is why they want to take this kind of cautious approach to begin with, not have officers out there boldly using screeners, everywhere, and this concern around the fact that they might not get blood. I'd be interested to know what the position is in other countries with per se limits, like Australia, whether this has been an issue of the police are concerned with, obviously, social media, and these are people who are actually already committing an offence by taking illegal drugs, would have no qualms about pushing the law a little bit further and not giving blood and saying they've got needle phobia, and social media would spread that message around that this is the way to get around the offence. I'm not sure that that's going to happen, but this is what the police concerns are, and I'd be interested to know if that's happened in Australia.
Martin.
Yeah, Martin Borman from Victoria Police. We confirm in saliva, so we don't have that issue of a concern about not going to a blood sample. Over the last year, in fact, there was 2,500 people charged with driving with a prescribed illicit drug present. Since we started in 2004, it's been getting close to 10,000 people we've charged, and there's not been one appeal. The people that are consuming an illicit drug and then driving know it, and it's not about the screening device. The confirmatory analysis by a gold standard LCMS is the evidence that's alleged against them. So we just don't get challenges.
Okay.
I've got a question for Rachel. You're doing a report for the Minister.
Yes.
Does the session today give you cause to pause on some of the recommendations you might give? Because I know one of the things that we do in New Zealand is the law is around good cause to suspect. You know, you're noticing a car that's weaving or whatever. Has Transport formed a view yet whether they will loosen up on that, whether New Zealand regime will become more of a random regime?
Well, that's one of the issues that's within scope of our review. We haven't formed any view ourselves, but it certainly is there. I was with a group of people coming out with some options, and the random testing is one of the options that we'll have to consider.
Okay. But we haven't got a view yet.
No.
Okay.
And we probably need to find out, I don't know whether people realise that the Minister has changed. We've got a new Associate Minister, it's Craig Foss, in whose area this will fall, and we haven't had an opportunity to brief him on this particular issue yet, so we will be wanting to test out the Minister's views on how he sees this sort of going.
Question over here. They're coming. No, they're coming. We need the microphones because we're filming you.
I'm not presenting my stuff on benzodiazepines tomorrow, but given that we know the synergistic effect of the benzos with alcohol, would it not be reasonable to have zero tolerance for alcohol with anybody taking benzos, regardless of the medical reason for benzos being prescribed? There just seems to be no reason at all that a person legitimately prescribed benzodiazepines should also be drinking.
Mark, do you want to?
Amen.
And you call that an aggravated alcohol offence? Would that be the charge?
Yeah.
No, but the question that's raised, it seems to me, it's an aggravated alcohol offense if you're already above the alcohol limit. Question is, what if you're high on benzos and you're also at 0.04 BAC, which is legal? Right? Are you an impaired driver? It seems to me the answer is obviously yes.
The answer is yes.
Right, and that was the proposal I put forward tentatively about cannabis. It's much more obviously valid with the benzos.
I mean, if somebody in the UK was under the benzo specified limit and had been taking alcohol and was clearly impaired, then we have the Section 4 impairment offence, which is why we're not getting rid of it.
But the public education should surely be don't drink if you're on benzos. Zero. Yeah. Yeah.
And that certainly might be the focus that we need to do.
The expert panel did make some recommendations for combination of drug and drink, so lower limits for both the drugs and the drinks. And the government is considering that, but they thought it would be too complex for the police to introduce at the same time. So let's concentrate on the specified limits for the drugs, and we will consider the combination at a later date.
Gordon?
Yeah, well,
Yeah.
One of the specific things I think that comes out of this, and sort of the more I read about it, is what the key issue from an enforcement point of view is you've got to identify impairment, and that's how the whole process starts. Yeah. And to me, impaired driving is impaired driving, and it's evidenced by the initial suspicion, and then you do a roadside impairment test or whatever you do, and then the drug is confirmatory. The reason that's not really the issue. To me, the interesting issue is what are we going to do about the people that get injured? Because we certainly know in alcohol area that if you get injured, it's protective to go to the hospital and be hospitalised, because it's too hard to test and you can't do the roadside test for impairment and all of those kinds of things. So it does present a challenge. I don't know the answer. That's why I brought it up as a challenge, because I think, to me, it's a no-brainer on the highway if someone's swerving and is impaired, and then you go through collecting the evidence. But the problem is someone who causes the crash and you really don't know.
They might not have caused the crash, but they could
Still be, exactly. They may have had no role in causing the crash whatsoever. They could have been innocently hit by a truck driver, but it just so happens they smoked marijuana the day or the month beforehand, depending on how accurate you're going to be your test is.
So we've got Paul and then Martin.
The jury that looked at simplifying, like the advice on medicinal products, sort of traffic-like, because a lot of patients just don't understand, and also the suggestion that you could work with clinicians about prescribing drugs that had a better safety ratio. We just heard the thing about don't drink if you're on certain types of drugs. None of this is really being, it seems to me, promoted, or there doesn't seem a lot of policy push on this, and I haven't heard, don't know what has happened about the ideas for simplified guidelines. I suspect there was some pushback from the pharmaceutical industry on that one. But why aren't we seeing more activity in the very simple prevention, training, labelling, simplifying of guidelines, all the obvious stuff, rather than just to focus on, enforcement and detection?
Ross, I'll just speak on that. We are working, obviously, with the Department of Health, because during the public consultation on our specified limits and drugs, it came up that doctors are not really having these discussions with their patients. And so we saw this new offence as an opportunity, as a starting point, to start at impairment. So to remind doctors that you should be having these conversations with your patients about impaired to drive, and we've issued some guidance to healthcare professionals with that starting point first, and then moving on to the new drug driving offence and the need to carry evidence of prescriptions if you did need to apply the medical defence. So we're working on that. The patient information leaflets, so all the affected medicines have pretty well all been amended by now. They were working to this date of sort of 1st October, which we thought we might bring the offence in. So they should all be amended by now, with specific references to the new offence and reminders about driving whilst impaired. So there is some movement on that.
Martin.
Yes, I'd just like to respond to Gordon's point about the hospital cases. In Victoria, we have a process where we have compulsory blood sample for collision victims, and we also have been screening those for the 3 prescribed illicit drugs since 2009, and it's quite evident there's a substantial proportion of people involved in collisions using those illicit drugs. In fact, we take about 3,500 blood samples. About almost 1,000 of those are positive to alcohol or drugs, and around about 400 are positive to the illicit drugs. So, likewise, we have all our fatal collision bloods tested as well. So we have some very good indicators that, despite some of the things I've heard today, that illicit drugs are very prominent in our road trauma, in addition to alcohol.
And do you still prosecute the people who from the hospital test? Because it's been shown incredibly protective. You never get prosecuted for alcohol offence if you get seriously injured.
We prosecute everybody that's detected with the presence of an illicit drug or alcohol over the prescribed concentration of alcohol gets prosecuted.
Miss Rachel, is New Zealand having these conversations we're talking about with New Zealand doctors about these testing for drugs?
Yes, and I think Margaret, is she here?
Yeah, we've
Because I
got
know
to-
in
She's
rural
gonna be talking about
areas,
that
I know in
tomorrow.
rural areas, a lot of those doctors are old, they're ready to retire.
Yeah.
So I'm just wondering.
Yeah, I think that's an issue that there is a, somebody's going to give a presentation tomorrow where they're doing a pilot study, and I think that has been one of the issues that has come up, that the medical profession do not, as in other countries, appear to be having these sort of conversations with their patients in as much as we would like, because I would have thought that that if you were prescribed a treatment that had potential side effects, that it would be the doctor's basic duty of care to discuss those with you as part of the, that conversation that they ought to be having. Now, I know that doctors are under a lot of pressure, and they've got a waiting room full of people still waiting. So it might be just a case of us, having to do. I think we do need to do more work with the medical profession and the pharmacists to make sure that they understand, what the potential, the advice that they should be giving to patients. It's sort of, it's interesting that we do have a document which is called Medical Aspects of Fitness to Drive, which is a guide to medical practitioners about all sorts of medical conditions relating to driving. And there is a list there of the potentially impairing drugs that we would think that doctors should be discussing with patients if they prescribe them. I'm not sure how many doctors actually know of the existence of. Well, I hope that they would be, or whether they're looking into the, right through the document to see what the advice is.
Just a comment with respect to what Mark said about the oral cheek test, screening test. We've been doing it since 2004, and one of the hold-ups was actually getting the screening test adapted so that it would be totally specific for Delta 9 and would not pick up the carboxy. And the proof now is we're doing 100,000 tests, of which 2,000 positives, and the prosecution is based on the lab LC MSMS, and we get 94% confirmations. So in answer to your query, is there, if we do, we have got a test, oral fluid test, that is very specific just to Delta 9. And because the levels are high, because it's a general deterrence program, you would have to have been using it within 6 hours to test positive. So all the figures about cannabis prevalence with the carboxy are not relevant to the legal situation.
That sounds good. Let me follow up. So you got a 6% false positive rate. So are those all confirmed by mass spec before you go to prosecution? Okay. So that's somewhat expensive, but at least it's very specific to the offense. That seems to me utterly reasonable. The point I'd like to make is, I'm glad to hear that Scotland is lagging, because that gives you a natural experiment. Right? If this is a road safety program, then you expect to see highway fatalities go down in England and Wales and not in Scotland. And if that doesn't happen, then you have a failed road safety program, which then stands there as a bit of culture war. In the U.S., where it turns out on better analysis, the wide open medical marijuana states, Montana, Colorado, Oregon, Washington, California, you do in fact see increases in cannabis prevalence, including cannabis prevalence among teenagers, as a result of that medical marijuana law. You can actually also look at highway fatalities. Now, causation of highway fatalities is very hard. There's an argument about whether you see an actual decrease in highway fatalities in those states compared to prediction, or whether there's no measurable change. But neither the explosion in cannabis use nationwide nor the specific explosion in the wide open medical marijuana states seems to have any impact, any bad impact, on traffic safety.
Question at the back, that'll be the, no question, fantastic. So we've got a difficult job tomorrow to figure out where our consensus. No, Rita's like, I've got it done.
I think possibly if you arrange for my assassination overnight, you might be left with a consensus.
No, you guys can go out to tea tonight. And,
Ross,
final question from.
sorry, you go first.
Perhaps just before we start panicking about how the heck are we going to achieve consensus, we could achieve consensus on maybe the main components. Like we focused in today because the session is on legislative and policy changes. We have sessions on prevention and public awareness and things of that nature. There's other components of an effective drugs and driving program. We could also achieve consensus not on the solutions, but on the questions that need to be asked.
Yeah, sure.
And I think that's where I was going, is so when we talk about legislative and policy options, what should a country ask themselves in terms of before you move to the answer? What are the what is the specific issue that a particular country is dealing with, whether it be benzos in an area or whether it be something else? But you should be asking yourselves, and that's where I was going with the consensus, is perhaps we could agree on what are the components and then what are the questions one should be asking, with some examples of what different countries have done to answer those questions.
Well, I got one little plea just on that.
It's going to be a quickie.
Is that when we do these big programs and make this law change, so little money gets spent on the evaluation.
Yeah. Mm-hmm.
And to come back on when we don't have a lack of survey data, then I think it's imperative to do something like a roadside survey. Can it collect the baseline? You don't have anything. The roadside survey, a good roadside survey, can at least give you your background prevalence before you start.
Yep.
And therefore you're defining the problem.
Yeah, and you're defining the problem as well.
You need to define the problem before you look at the solution.
Yeah.
Fantastic. You're okay?
I think Rita's
She's fixed us.
has fixed it. I was going to say something a bit more confident.
How much money on the whole program?
I was interested in to see, as obviously Mark and I have conflicting views, to see where we are at the moment.
At least I have a conflict with your Prime Minister.
Yeah.
I'm not sure about your views.
I do what the Prime Minister tells me, unfortunately. To see where we are, whether people think the UK law is the right way to go, or just think it's...
Well, how about what I propose, therefore, is let's break for afternoon tea. You can think about that challenge. Where do you... It's like a survivor who's going to vote. We're going to vote Mark off the team, or we're going to vote Martin off the team.